Good morning, friends. We are here for the course on PHAKIC IOL. Learn it from the masters. With me, I am Dr. BHASIN. With me, we have Dr. Partha Biswas, who will be speaking on the correct way to do ICL and toric ICL. Then Dr. Ramamurthy, who will be adding his experience by Indian PHAKIC lens. Then Dr. Sudhank Bharti, with managing complications in PHAKIC IOL, and Dr. Sri Ganesh, who will be speaking on managing challenging situations of PHAKIC IOL. So, PHAKIC IOL is in practice in vogue, and I have been practicing this for last almost 18 years. And before that, I used to use very size lens, which was an iris claw lens, and I did almost good number of cases, around 30 odd iris claw lenses, but there were limitations and many issues, and we were not able to correct toricity. Then it was in the anterior chamber, so case selection was also a challenge. So now we have moved completely to the posterior chamber phakic lens. So before starting, before going further, my first talk, I will be taking you into how we should plan, and that is very, very important. The pre-operative workup planning of a phakic IOL, because the technique per se is not very difficult. But the pre-operative planning and case selection is one of the most challenging and important thing. I don't have any financial interest in this. A phakic lens is an intraocular lens placed inside the eye and in front of patient's natural lens to correct their refractive error. And this could be the angle supported, iris fixed, or the posterior chamber phakic IOLs. This course mainly will add on to the posterior chamber phakic IOL. Before taking you further, let me show you a case where you will get an orientation how it is done. We make a 3.2 millimeter incision. The lens comes in a BSS solution, and this is the cartridge. This lens is very thin, and with front loading technique, we pull the lens in the cartridge nozzle, and with the soft tip plunger in the cartridge and injector system, the lens is pushed inside the anterior chamber in the presence of viscoelastic, and the four haptics, this is a plate haptic lens, the four haptics are then pushed behind the iris with a special spatula. And this is a toric lens, and the axis of the toric lens is aligned with the marks which we are doing, or in this particular case we have used Varion, and the rotational stability is very high in these cases, in all these cases. So the quest for the phakic lens started way back in 1953, and various prototype, various designs were developed, and but none of them were successful because of the poor position, poor design, poor quality, and everything. So then came the iris fixed very size phakic IOL, which was FDA approved, made up of PMMA material. The results were highly predictable and was relatively safe, but we required large incision, which induced astigmatism. Large means 5.5 millimeter incision, and endothelial cell loss was one important issue which was there. But if your this thing was good, case selection was good, there was not edge clear and disinclination, as in this particular case you can see one haptic is dislodged and lying in the anterior chamber in the lower side. So this was was commonly seen. Then the flexible model or foldable version came, which didn't got any FDA approval. And acris of Cachet lens also came some 8-10 years back, but it also didn't got popularized. So the the present phakic lens, which is the plate haptic type of a lens, the prototype was developed or given by Fedorov from Russia in the year 1986, and the first this was a collar button or mushroom configuration. The advantages of posterior chamber phakic lens is that it can surgically correct high degrees of myopia that cannot be corrected otherwise. We can correct up to 18, 20 or even more. It may be performed in patients who are not the candidate for LASIK due to corneal irregularity or thinness. So in low myopes also we can use this. And it is less likely to cause or contribute to dry eye. Sir, you can come, Dr. Bharti, please come on the dais. Less likely to cause or contribute to dry eyes, because surgical there is no the damage to the corneal nerves. It remains behind the iris, so there is an excellent cosmesis, and it is invisible to anybody from outside, and it is far from the endothelium, close to the nodal point of the eye, so there is a gain in retinal size image. Located in the sulcus, stable location allows for toric design and easily removable. This is the most important thing, exchangeable or reversible, no fixation into tissues, and does not alter shape or remove tissue and lead to a corneal based problems. It has a central vault, and as you can see here, this is the vault, means the central part is anteriorly this thing anteriorly, the convexity is there. It is foldable, that is the good part. It absorbs UV radiation, but definitely there is a sizing issue which we'll be discussing later, and it is made up of a polymer material. Coming to this material is biocompatible, and it attracts a layer of fibronectin. As you can see, the dashes are there on the surface of the lens. Fibronectin inhibits the deposition of other proteins which are present in the aqueous humor. The polymer lens is not recognized as a foreign body. So even in the long run, in 20 years, 15, 20 years, you don't see there is any deposit or pigment dispersion or pigment on the surface of the lens, unless until it is touching the iris. So the transparency is very good. It is maximum. Molecular size is 100 nanometer, and that's why it gives a better optical performance, excellent transmittance, and low reflectance pattern. It is very flexible, foldable, and can be easily injected through small incision. And it doesn't. There is a very less amount of glare and halo, and sometimes it is there in the initial phase due to the presence of center hole. Coming to the Centraflow ICL, which belongs to the ICL V4 family, it has a 360 micron central opening, which is designed to restore more natural aqueous flow and eliminates the need for iridotomies. Earlier, we had to do one iridotomy either by YAG laser before or during the surgery itself. But now, because of this 360 micron central opening and a tube opening on the side, which are acts for the redundancy, it maintains the balance, equilibrates the fluid aqueous balance in front and behind the lens, and that's why the nutrition of our crystalline lens is not hampered, and the quality and the clarity of lens and the development of cataract is further. Sir, please come on the dais, Dr. Ramamurthy sir. And this helps for the OVD removal and provides redundancy for the central optic port. The EVO, now what we are using is EVO plus Vision ICL, which has a larger optic size, 5 millimeter to 6 millimeter, depending on the power of the ICL. And this gives a better quality of vision, and the chances of glare is minimized further, and night driving in the white population is better. It is available in myopic eyes for from 0.5 to minus 18 diopters. Toric lens comes with the addition of plus 6 diopters cylindrical power correction, And in hyperope, we can correct up to 10 diopters, and again we can correct up to 6 diopters of the astigmatism. It is available in 0.25 diopter steps from 0.50 to -3 diopters, and beyond that it is available in a zero point 0.5 diopters of increments. The lens size in hyperopic eyes, we can get a smaller lens of 11.6, which is not very frequently available, but routinely 12.1, 12.6, and 13.2 millimeter size are frequently used. And in a very high myopes, when the large white to white is there, we can order for a 13.7 millimeter lens also. In hyperopic models are without the centraflow. That is a disadvantage as of now. And coming to the Indian counterpart, the IPCL, the good part is the design is similar, and there is a central opening in this. We don't require now the peripheral iodotomy to be made. But the good part is, another good part is that we can correct up to -30 diopters from -1 diopters, and in plus hyperopic eyes we can correct up to +15 diopters, and we can correct up to +10 diopters of cylindrical power. And in presbyopic lenses, we can have a +1 to +4 diopters of near add, and they can be customized as per the size, white to white sizing of the sulcus or scleral, the between the sclera on either side. So we can customize the sizing also. And so this is the presbyopic lens, which is also available. But I think Dr. Ramamurthy will be speaking on this. And it is indicated in the eyes from in the patients of 21 to 45 years of age. Refraction stability should be there in all these eyes from less than 0.5 diopter change in 1 year. It is for the LASIK. It can be used for LASIK rejects when there is a very high myopia or the corneal thickness is less than 500 microns with the large pupils, presence of dry eye, excessively flat or steep cornea when there is a keratoconus suspect. In such cases, also we can go for these phakic lenses. The contraindications are the presence of lens opacity, pseudo-exfoliation, coloboma lens, zonulopathy, pigment dispersion, or any previous ophthalmic surgery which is relative, and any other ocular pathology like glaucoma, intraocular inflammation, corneal degeneration dystrophy, macular pathology like CNVM or macular edema. Complete ophthalmic assessment, uncorrected and best corrected visual acuity, refraction, manifest and cycloplegic, complete slit lamp examination, normal IOP, open angles grade 3 to 4 Sheffer, and corneal topography and keratometry tomography, all is done. And in all these cases, endothelial cell count should be more than or equal to 2000, and fundus examination, and in the case it should be normal peripheral retina, or if there are any lesion, they should be treated beforehand by photocoagulation. The two important thing is the measurement of anterior chamber depth, which has to be looked upon, and it should be more than or equal to 2.80 millimeter, excluding the corneal thickness, and the corneal horizontal white to white distance should be measured. So this is the anterior chamber depth as I have depicted here. It should be internal anterior chamber depth, which should be 2.80 or more, and we have to check the white to white, and I do it in all my cases with digital caliper, as you can see on the bottom right side. And the other the things by which we can do it is OpScan, Pentacam, IL Master, UBM, vernier caliper, or some advanced autorefractometers. And this is how what we measure. This is depicted here, and this is a small video. Patient should be in a lying position under the microscope in high resolution from middle of the limbus to the middle of the limbus on either side. This is how it is checked. And pre-treat the eyes with anesthetic drops. This is 11.16, and we should calibrate the caliper before use. And sometimes in the when the arcus is thin or thick, or in juvenile arcus analysis, or in the allergic patient, then it becomes you find it difficult. But we have to measure it, and otherwise the vault will not be as good. Coming to the vault, accurate preoperative white to white and AC depth measurement is very, very important, because it is related to the presence of vault. Now, vault is the distance between the anterior surface of crystalline lens and the posterior surface of the ICL, as you can see, and it is in the bottom red arrow. And you have to compare this with the corneal thickness on slit lamp. So in this particular case, it is more or less same. So if we take the corneal thickness is around 500, so the normal this vault is around 500 microns. The normal vault is between 0.25 to 0.75 millimeter, or half the corneal thickness to 1.5 times of the corneal thickness. This comes in the normal category. If it is less than below 0.125 millimeter, then it is a low vault, and it can cause anterior subcapsular cataract. And if it is more than 1 millimeter, or double the size of the corneal thickness, then there is a chance of development of the cornea, glaucoma and pigment dispersion. And this is the vault which we can see on the left side, and the low vault on the right side. So now the ICL comes with this kind of a sheet, wherein you will see all the preoperative workup is mentioned over here. What is the spherical power with cylindrical power, what is the axis, what is the keratometry, anterior chamber depth, corneal thickness, white to white measurement. And on the right side, they will tell us which model of the lens, 12.1 millimeter in this particular case, and minus 14.5 diopters with plus 1.5 diopter cylindrical correction. And the expected residual refractive power will also be depicted. And this is how it comes, and this is both the eyes of this another patient. And in this particular case, the corneal thickness was less, so that's why even in this low power of 3.5 and 3.75, we are doing a ICL. So I have done it in a power because some people don't want to go for the laser connection, or because it is a irreversible procedure, and less in 2 and 2.5 diopters power also we have done the ICL. And so all these case sheets are there which come along with, and this is the IPCL power, how they send the this thing. Now coming to the confidence which we all want to repose in all of you, that this is a recent means it came in December 2021, the 8 years outcome of implantation of posterior chamber phakic intraocular lens with a central port design for moderate to high ametropia. And you see the resultant power is very good, and in 8 years time the refraction and the results are predictable, and they remain the same, and there is no development of the cataract. So friends, it is a good option to do a refractive correction by ICL, and I thank you for your patient hearing. Any questions? We can take it now, or maybe later also.
I think very comprehensive coverage, Dr. Bhasin.
Thank you.
I mean, all delegates sitting here are competent anterior segment surgeons. I think more than the surgery itself is the correct evaluation and the decision when to operate, what lens to put in is most important, and you have covered it very nicely. One of the questions that's often asked is, yes, the cutoff according to the company was 3 millimeters earlier. Now they have dropped it down to 2.8 millimeters. What if the AC depth is 2.65 or 2.7? Is there a lower cutoff? Can you go ahead and implant in those cases? Would you like to clarify on that?
Yeah, definitely. Sir, the company says that it is 2.8 millimeter, but in a personal way, I have done it in 2.7 millimeter also, and really the development of cataract and the vault is not an issue. Even with 2.7 millimeter, we can go ahead and do this thing, the phakic lens, in my personal experience.
I would slightly differ on this. Yes, Dr. Swaz.
Mike, please.
Please come to the mic. I would just like to clarify that I personally differ slightly on this, in the sense that I stick to a 2.8 millimeters, because you might do it on a 2.7 millimeter and get away with it. But the other factors, imponderables like lens raise and other things, which has an impact also. And doing a YAG iridotomy, when you have a central flow, really doesn't save you anything, because there's already a communication between the back of the lens and the front of the lens. So these are young patients in the prime of the productive life. So my take would be that, 2.8, 2.78, it's okay. And especially the high hyperopic, high myopic lenses, higher the power, the thicker the periphery of the lens. So these are the cases where you are tempted to make a compromise, and you might end up with a suboptimal outcome with the shallowing of the anterior chamber. So by and large, sticking to that standard of 2.8 is what we recommend across our centers.
I just wanted to know, since you have been doing ICL for a long, long time, have you in your patients observed that over a time the vault has decreased? Documented.
We have not documented. I have not documented personally, but we have this thing of 13 years old. We did it, and then we see those patients. Although during those days the central opening was also not there, but vault is still present, and no development of cataract is there, but definitely the incidence of cataract with the earlier type of lenses was high, and we come across now with the case of cataract in such eyes.
I think your question is very relevant, Dr. Suhas. All of us know that the lens thickens with aging. So that is a concern. We are operating on patients at 20, 25, and it has to subsist for them till such time as we go ahead and remove their lenses for cataract surgery. So because of this, it's also said that the lens thickens at the rate of about 0.1 to 0.12 millimeter for every decade of the lifetime of the patient. So obviously, if we say we are going to leave behind a 0.5 millimeter vault, in 20 years, this is going to come down quite. That's logical. But the thing is, this lens is not resting on the artificial lens that we are putting is not resting on the natural lens, but it is situated in the sulcus. And when this lens moves forward, there is also a commensurate movement of the phakic intraocular lens. So now the first phakic intraocular lens was implanted way back in 1988. And we have our own experience. We have almost a couple of decades of follow-up. And this kind of a shallowing of the vault is not something that's documented or established. Otherwise, all these patients would be landing up with cataracts 10, 15 years down the line.
So, in your experience, Dr. Ramurthy, what has been the minimum vault that you saw in your patient and just carried on, and you're happy that the lens is sitting there in spite of absolute proximity to the lens?
Absolutely. I think I'm going to actually be showing that in my presentation. We have cases with 84 microns, 100 microns vault, established, measured on the AIOCT. I'll be showing a picture of that also. As far as there is no onset of the anterior capsule is pristine, there's no onset of cataract, we really just follow up these patients. Similarly, again, what Dr. BHASIN said, 250 to 750 is our ideal way to go. We also have patients with 1,000 micron vault, where still the angles are open, more than 30 degrees open. There is no zipping up of the angles that's happening. We just follow them up serially, at least at a 6-monthly basis. So even though it's said that less than 150 microns, beyond 850 microns, you tend to exchange the lens, we are not doing it. But now the premise is that you follow up these cases for onset of the tiniest onset of any complications when you intervene.
If you see a lens opacity happening and the patient has no issues and continues to have good vision, would you still remove the lens?
I would, in the sense that if there is a small onset of anterior subcorpuscular cataract, which is happening a little peripherally, and I find the vault is about 85 microns, 100 microns, I will go ahead and exchange that lens.
But what's the logic behind?
Because you are going to put a higher sized lens so that the vault becomes bigger.
IOL exchange.
Yes. Okay. Because the vault occurs because the lens is slightly smaller than what it should be. So when you, supposing you have a 11 millimeter lens, and the Indian lenses are available at slots of 0.25, so you'll put 11.25 or 11.5 millimeter. So that will automatically increase the vault. We have done that also.
That's even when the patient has come 5 years later and now you start seeing a lens opacity.
Usually, these problems which are seen within the first 6 months or 1 year of the patient. Supposing, 4 to 5 years later, this doesn't occur. And the good thing is, as was told by Dr. BHASIN, these problems were more when the central flow was not there. Now, not only the ICL, all phakic intraocular lens come with a central hole. And we find that because of the flow of the aqueous from the back of the lens to the front, the incidence of cataract is definitely less. Though I do see quite a few of my patients turning up now, patients whom we have operated 10, 15 years back with an anterior subcapsular cataract. And as you also know that these myopes are prone for early cataract. So if it's a nuclear sclerotic cataract, then it's really not the lens which is at fault. It's just that high myopic patients are prone for these cataracts, in which case you have to handle it.
So it's only those that are directly because of your ICL proximity, and if you see those opacity, that is when you'll intervene early.
Absolutely. Anterior subcapsular opacity. Usually it's a fibrotic opacity.
And I think when it is even early anterior subcapsular opacity, we can wait till it is not obstructing their lifestyle. Because then unless until it is progressed, I think
I would slightly differ on that, because once it comes to the center of the lens, the case is already lost. I mean, the natural lens has to come out. So when it happens in the periphery, you start seeing opacity coming up there. Then that's when you can rescue this case by just exchanging the lens. But supposing the opacity already crept on into the center of the natural lens, then obviously just exchanging the lens is not going to reverse that cataract.
If I can share one case, the patient came with a very small dystrophic error. He was not good for LASIK. We put a lens. He was 6'6" and 6, but his proximity, his vault was absolutely minimal. So we asked for a bigger. He had given the biggest. He gave one size bigger. That was the biggest lens ICL had. We put that lens, and then again he was 6'6" and 6, young patient, and his vault is, in spite of the biggest lens, was varying. That was another question I want to ask. It would some visit it would be 34, some visit it would be 70, some visit it would go up to 120, again come back to 50. This is going on for the last 7 years. He is still 6'6", but he has now reached 40. Now I told him, and he also knows, that I say, we are not going to do anything because your lens is so close. If I have to remove it, there's nothing I can offer you except that, do your lens exchange. And anyway, he's not high myope. So that means with such low vault, sometimes miraculously the lens survives, and we can,
I think you have brought out an excellent point, and that's what I'm going to also explain. And vaulting is not just white to white alone. It's also a function of the keratometric readings, the AC depth, the lens rise. All these factors are there. So that is the reason for the same amount of white to white, the same kind of power, you calculate and put an intraocular lens, the phakic intraocular lens, the kind of wall that you see in two different cases might be significantly variable. So my premise is, unless there is a complication, unless there is onset of a cataract, or if it's a high vault, unless there is a crowding of the angles, just watch these patients as you're doing.
Sir, now I invite Dr. Ramamurthy, and he requires no introduction. He has got a tremendous experience of using phakic IOLs, and he will be sharing his experience on Indian phakic lens.
Thank you, Dr. Bhasin, for this kind invitation. It's always wonderful to participate in his excellent course, which offers a comprehensive coverage of phakic intraocular lenses. I'm going to be talking about Indian phakic intraocular lens, my experience. There is absolutely no financial interest. Basically, our practice now is about 50% ICL and 50% IPCL. We have also tried the other Indian phakic intraocular lenses, but purely because the relationship we use more of these IPCL, but the other alternatives that are also available. The approach to us as far as these phakic intraocular lens is concerned is very much like what we do as far as Indian and imported intraocular lenses are concerned. We do tell them that ICL is the first one off the block. It has certain considerations which makes there's a lot more experience with this. But if you cost is a consideration, which very often the case, because most patients require a bilateral toric implantation, and with a toric ICL, it becomes too expensive. So we do not want to deny this technology to our patients. So whenever it's necessary, we go ahead and counsel them and use both these lenses. So coming to the differences between these two current generation of these two lenses, the ICL generally, which is dispensed in BSS, corrects between plus 10 to minus 18 diopters, while the IPCL is available in a larger range of about plus 15 to minus 30. Again, astigmatism, there's a slightly higher range of correction that's possible with IPCL. This was one factor which kept me away from adapting these IPCLs a little earlier, because the collamer material, which is the most biocompatible material as far as the UVL biocompatibility is concerned, is what the ICL is made of, or rather it's a hydrophilic lens with a collamer coating on top, while the IPCL is made of the conventional hydrophilic acrylic material, which our intraocular lenses are made. But in our past experience about using these lenses for the last 7 to 8 years, we have not found any incidence of excessive inflammation because of the material of the lens. The ICL per se comes with a central hole and two paracentral holes, and it's in the leading right haptic and the trailing left haptic. While on the other hand, the IPCL comes with it's a more holy lens, in the sense it has got a central hole, two para-optic holes which should be situated superiorly, and there are also 4 holes on the haptics of the lens. Because of these holes, neither of these lenses require a peripheral iodotomy. Currently, most phakic intraocular lenses that are available all come with a central hole, which is 360 microns to 400 microns in size. This has a 4 haptic pads, this has 6 haptic pads, and these 6 haptic pads, the company claims, offers better stability. To my mind, both these lenses are equally stable once rightly implanted in the eye. As far as the ICL is concerned, most often we use both these lenses a toric version, because we want to take care of any cylinder that is there. And this is often got to be dialed into place, say 15 degrees, 30 degrees. But the toric IPCL, since more customized, you can place it at 0, 180 degrees, which makes the surgery little easier. The size of the holes creating a central hole itself was controversial. Kimiya Shimizu first came up with this concept, and they determined that if you have a 360 micron, that does not have any visual dysphotopsia impact, and the IPCL has a 400 micron central hole. And the most important aspect that you need to understand if you're using both these holes, as far as implanting these lenses in the right way is concerned, in the ICL, it is in the leading right haptic and the trailing left haptic, you have these holes, and these are the indications. In the IPCL, all the haptics have these holes, so that doesn't really help. What you see is it's in the leading left haptic, you have this collar stud, and in the trailing right haptic, you have this collar stud. So you have to ensure that you understand this and make sure the lens opens up in the right way. And because the lens is dispensed in BSS, the ICL, basically it remains in the same size after implantation. IPCL, since it's dispensed in saline, it enlarges a little bit in the first 1 or 2 days, so that the ideal vaulting you can determine after about 2 days of the surgery. The loading in ICL is a little different, and earlier days we used to be told that if you have learned loading of this ICL properly, then 50% of the surgery is over. But today my nursing personnel themselves very comfortably load these lenses, and in the IPCL is very similar to a plate haptic lens, and you just use saline to load these lenses. And as far as the optic size is concerned, it's slightly larger in a case of an IPCL, which obviously in these young myopic patients offers an advantage. The more important factor is that the IPCL being a local company, in case you come across highly mesopic size or scotopic size pupils, you can even custom make lenses of higher optical diameter without increasing the overall size of the lens. I already mentioned about these holes and haptics, so I'll skip that. Let's look at this video, and this is just the IPCL lens, because I'm supposed to be talking about the Indian lens. This is the collar stud I was talking about. This has to go to the leading left haptic, and this has to go to the trailing right haptic. And there is a central hole over here. All the haptics have those small holes, and there are 6 haptics in all, and there's also a central hole, and there is a paracentral hole. This is made up of hydrophilic acrylic material, extremely pliable, dispensed in a sachet of saline, and subsequently it has to be taken up, loaded, and then implanted. One of the things that you would notice that I am not dilating these pupils at all, because all of us who have done thousands of cataract surgeries have occasionally had an experience when you have a sudden entry of the blade and the anterior capsule gets touched by it. Obviously, if we have nicked the anterior capsule, what we do is to include it in our capsular excess, though it's not something right. But in a case of a phakic intraocular lens, if that happens, that's the end of the case, because the patient is going sure to develop a cataract. So I want the protection of the iris to be there when I'm making the incisions, and that's the reason these young patients usually dilate extremely well. Usually you make the side ports at 3 o'clock and 9 o'clock meridian. All these surgeries are done with the surgeon sitting temporally, and it's a 3 millimeter incision that I make temporally, because we do not want any wound assisted implantation. This is a mixture of phenylephrine and xylocaine that's being injected. As you can see, it dramatically, the pupil dilates. And it is also cohesive viscoelastic that I'm using. For a long time, it was told... For a long time, it used to be said that you should not use cohesive viscoelastic in these cases. I'm sorry about that. Because dispersive viscoelastic was what was recommended. But once the centra flow came up, we have started using the cohesive viscoelastic. And as you will see here, I don't even go in with the irrigation aspiration cannula. As I go ahead and hydrate the incisions, it just flows out. And that's the lens is always injected in front of the pupillary margin, in front of the iris. Then subsequently, using this spatulated instrument, you go ahead and introduce it, tuck it in just under the pupillary margin. It's extremely easy maneuver. Once you have done a few cases, you can easily master this. This is exactly what I was talking about. As I'm just hydrating the incisions, you see the entire viscoelastic coming out, because the occurrence of cataract during surgery is supposed to be most often occurring because during the irrigation aspiration step of the surgery, when inadvertently the anterior capsule is touched. And when you are not entering the anterior chamber at all with the irrigation aspiration, and the entire viscoelastic flows out as a bolus, that makes it much more controlled. And there is also another way of implanting these lenses, and that's a hydroimplantation. And essentially, I make the side port incisions, no dilatation, and then subsequently injecting a phenylephrine with xylocaine, certain amount of dilatation. When I introduce the cohesive viscoelastic, then the pupil will dilate even further. And most often in these young patients, dilatation in spite of the pigmented iris is not really a challenge. And you can see that it is happening quite comfortably. And even if you have a 5.5 to 6 millimeter pupil, you can. That's just an irrigation cannula that's inside, and no viscoelastic has been introduced. And with this, I'm able to introduce the lens, just like many of us do a hydroimplantation of the intraocular lens. I actually have a Varion overlay which is not showing up on the videos because of some incompatibility issues. Almost 75 to 80% of the lenses that we use are toric implants, and then you can also position these lenses under the hydroimplantation itself. Having said that, I found that this gives me a little less control, and more often I'm using under cohesive viscoelastic today. But this is one other way of doing it. Of course, you might have seen several videos of the lenses being implanted under HPMC, which is what most surgeons do even today. So, as far as presbyopic phakic intraocular lenses are concerned, IPCL is available today as a trifocal lens. ICL has already come up with a version, the EDOF version of the lenses are available in Europe. They say it should be. Can I take a couple of minutes? It's awaited in India. Maybe in another 6 months or so, it will become available. That the IPCL is essentially a trifocal diffractive lens, and you have an add power of from 1.5 to 3.5. And when you implant a +3 diopter lens, you get about 2.1 diopters for near and 1.2 diopters for intermediate. So even if the patient is just about 42, 43, we implant a +3 in one eye and +2.5 in other eye, because this lens has to serve the patient for the next 15, 20 years. Implanting just about a 1.5 or a 2 diopters will be quite inadequate, because what is labeled on the lens is actually the actual power in the lens, and what comes on the spectacles is significantly less, about 1/3 as far as the intermediate is concerned, about half as far as the 2/3 as far as the near is concerned. This is just the presbyopic IPCL implantation. The procedure is exactly the same. I just wanted to show you the diffractive rings. We have implanted about 50 of these lenses, analyzing results, and we'll be soon publishing it. But fortunately, we are concerned whether there will be significant amount of dysphotopsia. You can see those diffractive rings over there. But fortunately, that has not been the situation. And whenever the ICL is not in the proper position, you can always, all you need to do is to go in with the irrigation cannula, and just because I do not use any viscoelastic, with the digital overlay, you can exactly orient the lens where it should be. And this is very much doable with just a simple spatula, and you owe it to your patients to correct it in case it's not really in the right position. I think already Dr. BHASIN has dealt with this, but these are the IPCL sizing. The ICL comes in 0.5 millimeter steps, while this comes in steps of 0.25 millimeters. So it gives a little more option. Also, the fact that it comes from 11 to 14 millimeters. Exactly the question you asked, Dr. Suhas. You can see these patients operated about 5 years back. Right eye, the vault is just 117 microns. Left eye, the vault is just about 84 microns. And because the anterior capsule is pristine, we are not doing anything about it, but just following up. Similarly, a patient with 1,100 microns, but with this angle which is open, we are just following them up. That does not mean that we have to be careful of the fact that the angles don't zip up, and call them at least 3 to 6 months. This other eye, and you can see the fairly large vault in the slit lamp photograph also, and these patients can be followed up. But this is a patient who was developing crowding of the angles, and this is the way we exchange the lens, where again you can make a 3 millimeter, open up the initial incision itself, and all you need to do is to bring out one of the haptics out, and using a McPherson's forceps or the front loading forceps, go inside, use again a cohesive viscoelastic to form the chamber nicely, because both the ICL and IPCL was extremely pliable material. By just a hand over hand maneuver, you can bring the lens out. Sorry, somehow that step got edited out, but removing these lenses is quite easy. Then subsequently, you inject the lens. In this case, because for high vault, we actually reduced the size of the lens by about 0.5 millimeters and then reduced it and then implanted it. We have published on our experience with the these lenses, and the initial publication showed of 134 eyes analysis that is a safe and effective treatment modality for correction of myopia and myopic astigmatism. Then subsequently we did a comparative analysis where there was a cohort of patients, 119 patients who received IPCL and 203 eyes which patients who received ICL. We found that there was a fairly large analysis, but then I'm not going to go into the details. Both worked equally effectively. So suffice it to say that phakic intraocular lenses has come to stay as an integral part of the armamentarium that's available to a refractive surgeon of the third millennium. and the availability of alternatives which are a little more economical, obviously adds to the spectrum of patients for whom we can give the benefit of this technology. Thank you so much for your kind attention.
Thank you, Dr. Ramurthy. It was a brilliant talk, including all your experience which you have given in your talk. And any questions from the audience? So you say that Indian lenses are the IPCL. You have an experience with IPCL, and another company also makes it
Even I've
bioacrylic.
implanted the biotech lenses also. I implanted the lenses which come from Appasamy.
Appasamy.
Yeah, those lenses are also equally good. Actually, some of my consultants like the biotech lenses. It's just a matter of practice, that's all. I mean, I think all these lenses, once you understand them well, works equally well. And very limited experience with the Appa lenses, just because we not use them many, but otherwise I'm sure they'll also work well.
Okay. There is no excessive development of cataract or iris shaping or reaction post-operatively.
I don't think I can comment on that because, our numbers are very small with those lenses.
Not
But
with
as far
APA, but with IPCL
yeah,
or
with the
bioacrylic.
IPCL, definitely the incidence of cataract is no higher than what you would get with an ICL. And all the tenets that you very nicely elaborated needs to be observed even with these lenses.
Okay. The indications and the examination and the pre-operative assessment is same.
Absolutely the same. Absolutely the same.
Dr. Ramu, with regards to sizing of the lens, once you do your white-to-white measurements in the theater, do you have some other backups done in the diagnostic room with which you compare, and what's the kind of comparison you normally find?
It's a very relevant question in the sense that we do both with the digital calipers as was shown under the microscope, and then also we use either a topolizer or a OBSCAN to measure the white-to-white measurement. And ideally, both these measurements should be quite close to each other.
They're never same.
They're never the same. The reason we use both these instruments is that, obviously using a advanced equipment like a topolizer would be a good idea. But if you have a pigment or a blood vessel right at the limbus at 3 o'clock or a 9 o'clock meridian, that could give you a slightly larger measurement. So if these two measurements, and as was Dr. BHASIN was saying, you have to measure from mid-limbus to mid-limbus. And that's the reason you don't want to do it on the slit lamp or just with the patient lying down. Do it on the microscope with care. If there is a difference of more than 0.1 between the two measurements, I definitely ask for a remeasurements. And once it's done by an experienced, actually we have our optometrist doing it for us, we find that most often it corresponds. And in case you have to err on the side of you have to choose between the two measurements, we go for the slightly higher measurements because you don't want the lens to be sitting on the anterior capsule. A slightly larger vault is more acceptable than an extremely low vault. And generally we go with the instrumental measurements like the OBSCAN or the topolizer, because whatever we do digitally might be a little more erroneous, and that is subject to the person's variability of the person who is measuring it.
See, your lens star or IOL master also gives you a white to white.
No.
And also topolizer. So you would rely more on the topolizer.
No, I don't think you should use any biometer, optical biometer for doing this, because what you need is white to white. You need what all these instruments measure is sclera to sclera. That's the reason when you measure with the IOL master or a lens star, it will invariably give you about 0.3 to 0.5 millimeters higher.
Reading.
So that's the reason that you need to use a Scheimpflug instrument or a topographer to do the measurement and not rely upon a optical coherence. I mean, this
that's a good point.
laser interference biometry.
Yeah, there's always a difference of 0.4.
Absolutely. It's well accepted, well documented, and you will find a difference.
Thank you, Dr. Ramurthy.
So one thing that I would like to add to this is I use the caliper, the digital caliper and the IOL master all the time. And that difference I keep in mind so that it is absolutely that. But taking the caliper reading as the gold standard, means as the way to go forward. Because OBSCANs are no longer in use now, and we don't have an OBSCAN in of Calcutta et al.
Yeah, you are quite right.
May I request Dr. Partha? He requires no introduction. He is the chairman of scientific committee and has got very long experience of the use of a variety of lenses, PHAKIC lenses, and he will be speaking on the correct way to do ICL and toric ICL.
Thank you very much, Dr. BHASIN. And it's been a wonderful way the IC has been dealt and been accepted all over the years, as well as internationally also this IC is acceptable. So it is a very nice way of putting forth that how do we go ahead and do the correct way to do an ICL and a toric ICL. So with all the background that already has been said, I will just stick to my points of doing ICL the right way. So I'll straight away play the video in which we have the ICL and how to do it the correct way. And the correct way is very important. If it is not done the correct way, then it cannot be done rightly and the results are very, very poor. So topical anesthesia for one is very important. No peribulbar anesthesia. The loading of the haptic of the ICL is most important, and the loading has to be done in the cartridge, half filled with methyl cellulose as viscoelastic, taking off any bubbles in the cartridge itself and removing any bubbles that can come into the way, because that can go into the anterior chamber and occlude the view. So the next thing is removing the ICL from this container, and the container is in BSS. So this ICL is not going to expand in its dimensions once it is placed in the eye, which means that once it is placed in the eye, next day itself, you can understand that this is the vault, more, less, or optimal. Now, picking up with this applicator, and this is a very important applicator, do not use any other applicator than this, and then placing it very gently into the cartridge. It should not dehydrate during the process of the implantation, and thereby, if the time elapsed is more, then please put a drop of BSS on the ICL. Now, it is nudged in very gently, it will go in, and this is the Osdor forceps, which is supplied by the manufacturer to grasp it. And the grasp is important because it should grasp right in the middle, and there is a small hole in the middle. The grasping part of the forceps should part on that hole, and then drawing it very gently across. Both should move. The applicator should move as well as the forceps should move. So, and that is how very atraumatically it comes near the hub, but not beyond the end of the cartridge. Then it is placed into this cartridge and locked in. Once that is done, this should be dipped into the BSS once again and kept. Then comes the incisions. Do not make incisions before, or do not place an viscoelastic into the eye before loading the ICL, and it has to be done as atraumatically as possible. 2 side ports have to be made, and once the side ports are made, the amount of viscoelastic that you need to place in the anterior chamber should be just optimal. Now, what viscoelastic? The first viscoelastic that we have been using is methyl cellulose, but you can also use Helon, because Helon comes out in a bulk from the anterior chamber, and the amount of incision should be 3.2. This is one of my very initial videos where I had extended this 2.2 millimeters to 3.2, but it can go into 2.8 as well. So placing it in the cart in the anterior chamber and watching it unfold, and moving the cartridge a little as it unfolds so that the top hole is right on the top, and then pressing against the iris in the anterior chamber, not putting it behind the iris in the first go at all. So that these small tricks have to be kept in mind. And then the haptics are very, very simple, very small haptics, which just have to be tucked in. And the manipulator again has a curve which should be tucked in with the right way. No vigorous manipulations at all, and then the viscoelastic needs to be washed out. Now, washing out the viscoelastic is important as much as possible. The helon can come up in a go. The methyl cellulose needs to be taken up. At one time, it was thought that the central hole, which can flush out the methyl cellulose, can be taken off very simply, but it is best not to jet on that central hole, because it's been found that cataractus changes might take place if there's a jet going down for a very long time. So it's very simple, that's it, and good closure. But what is important is also the post-operative checkup. The first day, some people do it on the same day as well and see the vault. But the first day checkup is very important. The vault should be assessed, and it should be at least approximately 500 microns, 250 to 750 is acceptable. A little more or a little less can also get away, but you have to keep these patients on a check. And if you have done a toric ICL, it has to be in the proper position. At times, the movement can be there, but it's very, very rare. It stays very nicely in place. But if a movement has been there and the patient has lost vision and there is a decrease of vision in the first week, it needs to be retaken up for surgical maneuver, and it has to be placed in the correct axis. So wishful thinking that it will go back on its own is not correct. Unless it is a very small ICL and it has rotated quite a lot, then only needs to be taken out, otherwise not. So a toric ICL, if you have a markerless system in your theater, it is best to use the markerless system. If you do not have, even manual marking can do. For many years, I used the manual marking, and now we have the Callisto. So Callisto gives us a lot of advantage. It's very important that, with dilatation, you can see both the toric marks, and that makes it quite easy to assess whether everything is fine. So these are a few things that I wanted to share with you. Post-operative examination is very important. An intraocular pressure check is important. Usually we don't do it the first day unless there's corneal edema or anything. So 1 week measurement of the intraocular pressure is quite okay. But if the intraocular pressure is greater than 24 millimeters of mercury, or 10 millimeters greater than the pre-op, then that needs to be taken into account. And the IOP elevation is usually because of two reasons. One is retained methyl cellulose or retained viscoelastic, and the other is, if it has occurred a week later or so, it can be a steroid responder. For most myopes, for a percentage as high as 15 to 20% of myopes can be steroid responders, and this has to be kept in mind. And if that is so, then of course it has to be taken a call. What about iridotomies or iridectomies? We do not do iridectomies as of now, except if it is a hyperopic ICL. And of course, the PI should be checked if it is required. And these are a few slides just to show that if the PI has to be done, it has a very peripheral PI, but a large and a patent PI as such, which we usually do not do anymore. Now, if there is a high vault of the ICL, and this has to be taken into account, and these have to be washed. But if it goes from 750 to 800, 850, and the intraocular pressure is well maintained, and of course with these current ICL with the central flow, there's not a PI. We don't have to rush in to do a PI. We just have to keep a watch on the intraocular pressure, and gonio can be done intermittently. However, if there is an ICL with a low vault, so how low is low? So if it is less than 250, if it is in the range of 200 to 250, you can just very safely watch. If it is coming down, say in 2 months' time it is 200, and then in 6 months' time it is around 100 or 150, these are patients to be washed off. If it comes to less than 100, this lens definitely has to be removed. So the removal is not so difficult, and it's with the same incision that you can go in. A 3.2 can remove it very well, very atraumatically, and you can put in the correct size of the lens. However, if there is a low vault, In the first week itself, less than 100, that means the sizing has not been correct and this has to be replaced. Thank you very much for your patient hearing.
Can you bring up here?
If there are any questions, I'd be happy to answer.
Good morning, dear friends, and I would like to thank Dr. Purendra BHASIN for inviting me to give this talk in his IC on managing challenging situations. So you have seen how to implant, the proper technique of implantation of the PHAKIC IOL. So let us look at some situations, challenging situations. If you look at the I'm not able to advance the slide. Hello? Yeah. If you look at ICL complications, you can have a lot of complications. Pre-op, you can have problems with the refraction power. If you don't put in the power properly, you can have post-op residual refraction. Sizing is a big issue. I think it's the biggest issue with ICLs. Intra-op, you can have problems with wound construction, loading, insertion. Early post-op, you can have elevated IOP, traumatic cataract. Late post-op, you can have glare, halos, iris transillumination, cataract, glaucoma. Atypical long-term findings include pupil ovalization, iris transillumination, pigment on lens, and oversized ICL. Dr. Parthi also will be covering the complications. So I'll look at the challenging cases. So this is, while inserting, I think Dr. Partha kind of alluded as to how to inject the lens properly. Here the ICL flips. Again, if you don't load it properly, if you don't see that all the three lines are in alignment, it has flipped and gone in the opposite direction. So here, basically, I'm trying to kind of flip it in the eye because it has gone upside down. I'm trying to flip it in the eye. So using a visco cannula, this is a Helon cannula, I try to flip it. So again, for beginners, you may want to remove the ICL and insert it because flipping maneuvers can damage the endothelium and damage the crystalline lens. So you have to be very careful. Here I'm putting adequate viscoelastic to deepen the chamber. And then you can see that I'm engaging the hole, the center flow there with the cannula and then pushing it. And this flips the ICL. So that's a small trick that you can engage the hole. Otherwise, sometimes it's difficult to flip. Then I use a Vukich manipulator to center the lens and then insert the haptics under the iris. Okay. And that's the trailing haptics which are inserted, and then I was able to kind of get away with this. But ideally for beginners, if you have a ICL that goes upside down, then it is better to explant it, reload it, and then inject it. It's very important to look at the landmarks, and for the ICL, the leading haptic, the hole has to be on the left side, right side, and the trailing haptic on the left side. So this is a video of how to explant and reinsert the ICL if it flips. So I put in viscoelastic, I'm injecting. So at this point, if you feel that the lenses, don't inject it completely. If you feel that the landmarks are not clear or you're not loaded the lens, you can withdraw it. You can withdraw it and then inject it. But here you can see that it has flipped. It has flipped completely. So when it flips completely, then it is difficult to kind of flip it back. And in a flipped lens, the vault is almost zero. It's touching the anterior capsule of the lens, and you can have a very early cataract developing. So it's very important to remove this lens and reinsert it. I like to extend. This was a wound-assisted insertion, so I extend it to about 3 millimeters. Then I go with the ICL loading forceps. I grab it at the optic haptic junction, and then with a twisting motion, I am able to pull the ICL out. And after I pull it out, then I am again reloading it into the cartridge. So now when you load it, you make sure of the landmarks, and then when you use the pull-through technique, you ensure that all three holes in the center flow and the peripheral holes are aligned in one line. If it's aligned in one line, and as you're injecting the lens, you also see the direction it is coming in, and you can rotate your wrist so that it comes out in the proper way. And you can see that now I've inserted it in the proper way, and then I'm tucking the haptics in. So that is the cannula which I use. That's the Ganesh cannula. So you can inject viscoelastic. It is sandblasted on the undersurface, and you can use it to tuck in also. It's available with Epsilon. So this is a patient with a high vault who ended up with a high vault. It's a 21-year-old female. Refraction was -9, a very small cylinder. So we decided to use a ICL, both eyes 13.2 mm, 10.5 power and 11. She underwent uneventful ICL surgery, and then on the 5th post-op day, we saw that the vault was very high. The AIOCT showed that in the right eye, the vault was 1.29 millimeters and left eye 1.24. So almost 1300 microns per vault. So it's a very high vault. So what do you do in this case? And this is interesting. Now, if you look at the white to white, the limbus, the white to white is maximum in the horizontal and minimum in the vertical, but with the sulcus, it is the opposite. The maximum diameter is in the vertical direction and the minimal in the horizontal direction. So here what I decided to do was, I decided to rotate the lens. Sorry, let me just... So you can see this is the AIOCT. So before rotation, the right eye it was 1.29 mm and left eye 1.24 in the center. So these are cases, if you have a very high vault, then you can have occludable angles, and it can go in for an angle closure. So what I am doing here is I am rotating the lens. I just go with BSS. You can put in a little bit of viscoelastic so that the chamber does not collapse. I'm using my cannula where I can inject viscoelastic at the same time and also use it as a manipulator. And then I gently rotate the lens into the vertical position so that the haptics are placed vertically. So very gently you can rotate it. Okay. Rotate it and place it, and then you can remove the viscoelastic and close the eye. So similar thing was done for the left eye. So this is the left eye where again I put in viscoelastic. Oops, sorry about that. And then rotate the lens vertically. So you can just wash out the viscoelastic if you use Helon, and you can see the post-op, it reduced from 1300 to 780, which is acceptable. So this is a small trick for a non-toric lens. You can just, and this is the left eye, which was 857. So it reduces by almost 500 microns if you rotate it vertically. So for a non-toric lens, you can use this. When you have a high vault, you just rotate the lens vertically, and then with that you should be able to get a lower vault and get away without an exchange. This was a high vault where we had to exchange. You can see that here the vault was 1.57, and you can see the angle is very narrow, occludable angle. So you should not leave these lenses like this, otherwise over a period of time it will go in for a angle closure. We also did the UBM and saw the sulcus to sulcus, and then we selected a 12.1 mm from a 13.2. So we went down 2 sizes because the vault was very high, and this is the technique of explantation and then reimplantation of the lens. So here I am making a side port and I open the main incision. You can slightly extend it to 3 or 3.2 mm because you want to be able to remove the lens easily without traumatizing the wound. then what you do is you can just engage the hole there in the mid periphery and lift it up. Put viscoelastic, rotate the lens, and once you rotate the lens a little, then you can go in with your lens loading forceps, hold the optic haptic junction at, that is the thickest area of the lens, and then with a twisting motion you can remove it. And then of course, then you load the lens, the new lens, which is 12.1 mm, and then you can implant it. I'll just fast forward this video so that you can see that is and the end of the procedure where the new lens has been implanted, and you can look at the vault now. It is 406 microns, which is a very good normal vault. This is again ICL explantation and phaco. You can do a femto for such cases. If you are doing a femto, what happens is the femto scan recognizes the anterior surface of the ICL as the anterior capsule. So you need to offset it. Otherwise, you will not get a proper rhexis and you'll damage the lens. Here you can just kind of rotate the lens again and then explant it. And see, that is explantation. The same twisting motion, I remove the lens. You can remove it through a 3 mm. Then it's very important to use a rhexis forceps to peel off the flap of the anterior capsule, because there will be tissue bridges and you can have a runoff. And then that's the hydrodissection. Of course, these nuclei are usually very soft. And what I do is I use my technique of visco chop, where I just inject visco into the nucleotomies, and this separates the lens into a nice 4 quadrants, and then I'm able to aspirate it. That's a cortex removal. And then this patient was a very high myope, so I'm using an expand series, very low diopter IOL, so it's available in the 3-piece lens, and then I inject it. So for paucity of time, I will stop here. Those were a few of the challenging cases. Thank you very much for your attention. If there are any questions, I can take them. Otherwise, I have to run to my IC. Yes, please. Thank you. No. You have to switch on the mic. Yeah.
Yeah. So in the case where you flip the lens, when you're taking it out and flipping it back and putting it in, does it cause some sort of a micro aberration in the lens optic, which could cause aberrations later on?
No,
or
you are
not
holding.
really?
See, you hold the lens at the optic haptic junction. If you hold it at the haptic, it's very thin. It's 50 to 100 microns, and it can tear. The thickest part is the optic haptic junction, so you get a good grip there. And I use the lens holding forceps. If you use a MacPherson, it will slip. So I use the lens holding forceps, which is serrated, so I get a good grip on the lens. And then you need to kind of rotate it and twist it out, but it does not damage the optic, so that's not a problem.
So no post-op aberrations or?
No.
Thank you.
Thank you. Thank you. Of course, Dr. Bharti was supposed to speak on managing complications of phakic IOL. But since I think he has laryngitis and his voice, he cannot be heard. So Dr. Bhupesh will be giving this talk for him.
So thank you, Dr. Sri Ganesh. And I think you have covered almost all the complications and wonderfully managed complications. So I'll be just enumerating some of more complications of ICL. So first thing is that after ICL, you may need using glasses for near if you're above 40, or if there is undercorrection, then you need glasses for distance also. So in cases of residual refractive error, Bioptics is a good option to cover those residual errors. We can go for the PRK or LASIK after doing ICLs also. So that is a good option for managing the residual refractive error. ICL exchange is another option. If there is too much of disparity in the outcome, then you can exchange the ICL and put the correct ICL. In cases of high vault, the oversized ICLs not completely in sulcus, and sometimes OVD is behind the ICL. So you have to look for them. If there's high OVD, more OVD in the behind the ICL, the pressures will be high. So you need to remove it. If it is too oversized, as Dr. Shrikanesh told, that you can rotate it vertically. And if it is not managing with that also, then you need to explant and put the new ICL of proper size. B-scan, OCT, and UBM helps a lot for seeing the vault and the position and the sizing of the ICL. And high vault causes glaucoma. So previous designs we used to do iridotomy, but with the newer designs, you don't need to do iridotomy. And sometimes there is a retained visco. So AC wash is very important during the procedure. So make sure that there is no viscoelastic remnant behind the lens or in the antechamber. The AC has to be clear, and then close the eye. And in case of low vault, the main problem is the undersized ICL, and it can cause anterior subcapsular cataract. So we have to be very careful while sizing the ICL, and low vault can cause anterior subcapsular cataract. So we need to follow up these patients and how it is progressing. And if you think that there is any sign of anterior subcapsular cataract, it's best to exchange that lens. And as Dr. Shrikanesh told, that axis rotation works very well for the non-toric, but with the toric, it's difficult to rotate. You cannot rotate it, so you have to exchange it. So these are some of the complications like glaucoma. If the ICL is oversized or isn't correctly positioned, it can increase the pressure in the eye. Vision loss if high pressure lasts long. Early cataracts, blurry vision, cloudy cornea, retinal detachment, some sort of intraoperative infections, or you need additional surgery. So proper preoperative workup is very important. Detailed retina examination, sealing the weak areas of the retina, looking for the cataract status. Don't miss any pre-existing cataract or opacities in the lens. So we should avoid ICLs in those cases. And pressure management is very important. So we have seen that pressure rise is common after the ICL surgery. So always check the pressure in every visit and see how it is going. And always look for the vault clinically on the slit lamp. And if you think that it's too high or too big, always take the help of ASOCT or UBM. And once the lens is inside the eye, repositioning or removal of the IOL may be required if the lens is at the risk of damaging any intraocular structure, iris, or the lens. And the presence of cataract, history of any RD or serious retinal disease has to be taken care before, and patient has to be explained about its pre-existing diseases. Many patients have high myopia, so they have pathological myopia or amblyopia, or the perceptive visual acuity is not that great. So patient should know what is going to achieve after ICL. And these are some of the serious complications that you can encounter after ICL, although the rates are very low, like endophthalmitis, TAS, ocular hypertension, accidental anterior capsule rupture, trauma, ICL dislocation, and retinal detachment. And these are the list of most common complications that we encountered, like TAS, ENDOPH, ICL subluxation after blunt trauma, focal anterior cataract, large wart or small wart, and corneal edema. So we should always look for the health of the endothelium also before planning the ICL surgeries. Thank you.
Thank you, Dr. Bhupesh.
Thank you, ma'am.
That was an exhaustive and a scary list.
Yeah.
But having said that, I would say that today's day and age where you have the most advanced ICLs, also better technique to measure and instrumentation to handle the ICLs, the complication rate has reduced drastically, and it is coming out to be also a procedure of choice for those cases where you can't safely go on the cornea. So your refractive patients do have alternatives in terms of ICL.
Thank you, ma'am.
Right, sir? Anything else?
Thank you. Thank you, ma'am.
So it was really a good presentation. Thank you very much.
Thank you very much.
That gets us to the end of the session. Are there any questions for any of the speakers? Then on behalf of Dr. Bharti, I would like to say thank you to all of you and the faculty for making this session a complete success. Thank you very much.